Hello, fellow classmates, Jessica, my fellow group mates who I haven't seen. Welcome to my video. I will be continuing off going into the assessments, which Michaela started talking about. She spoke about the SS, the gain Q3, and the gain I. I will be continuing off there and give a brief overview, and then we'll be going in depth into the gain I and what really it entails and what its actual purpose is. So without further ado, here are the slides. Okay, so slide number one is basically the approach that it comes for screening. So we start off with the gain short screener, which is a brief screen for possibility of any substance use or mental disorder. Then we go to the gain Q3, which would be the next one done, which is a longer screen for specific substance use or mental disorders. And then into the gain I, which is a diagnostic assessment, and it also involves treatment planning. So the next slide, we're going to go a little more in depth to the gain I. And again, this is the process. So the gain Q3, which would be the first one administered, typically used in institutionalized settings such as detox, hospitals, juvenile systems, or prisons, etc., to get an overall picture of the client. If more treatment is deemed necessary, we'll usually conduct a gain I later in treatment for a more specific diagnosis. This is meant to help addressing possible co-occurring disorders early in the treatment and assessment process, which is very important, and that's going to lead us into the gain I. So the gain I, or the gain individual, its primary focus is it's used as a biopsychosocial assessment battery for people entering substance abuse mental health treatment. The gain is designed to help clinicians and researchers make diagnostic impressions about participants based on a DSM-4 criteria. So they do use the DSM-4 in the diagnosis. Obviously, us as SSWs will not be making diagnoses. These are done by, therapists and certified counselors. So because the gain is a self-report, which does not mean self-administered, it should be combined with other information and interpreted by an appropriately trained clinician. About 3% of the clients will have severe enough cognitive problems to limit its usefulness. So that would be any kind of severe mental disorder. An overlapping 5% will give answers that the assessor does not believe, either due to cognitive limits or lying, which happens quite a bit. And interpretation requires integration of information. So it does require other information. These are added to the client's files, and so you can take information from there. So continuing on with the gain I, the 3 substance use related diagnoses. So these are the way that these are broken down into the gain I for the eventual outcome. Their problems is the first criteria. These are substance-induced disorders and other problems associated with substance dependence and abuse. And then it goes on, the next level up would be abuse. These are symptoms suggesting that substance use activities are causing episodic problems and or role failures that are interfering with the participant's life. And then lastly, dependence, which is the symptom suggests that as a consequence of use, the participant's body has been physiologically changed. The participant is losing control of her body and behaviors, and that substance use activities are displacing normal activities, relationships, and responsibilities. So I'm sure if we go back to our addictions class, you all remember the definition of what an addiction entails, and that would certainly be it. So then the gain goes into physiological symptoms. So physiological symptoms may be identified when the criteria, identified when the criteria for dependence are met and there is evidence of tolerance or withdrawal. And specifying the presence or absence of physiological symptoms in the diagnosis is important for the greater likelihood of medical problems, withdrawal, cravings, relapse, and other treatment planning considerations. So definitely withdrawal being, medical stuff. This is where a medical detox would be required. So next we're continuing on with the physiological symptoms, which once again brings in the DSM-4. So consistent with the DSM-4, substance disorders in the GAIN are grouped into 11 classes. When sufficient symptoms are endorsed for each class, one of them will be listed in the GAIN reports. So these are within these three headings, there are 11 classes. So there is dependence with physiological symptoms, and then there is dependence without physiological symptoms, and then there is abuse. So next we're going to talk about personality disorders within the GAIN individual. So the GAIN's personality complexity scale is divided into 3 subscales for 3 personality clusters. Cautious Personality Index, which is the CPI, so that would be, from our mental health class, I'm sure you'll remember the different clusters of personality disorders. So for cluster A, which is paranoid, schizoid, and schizotypical personality disorders that characterize people who often appear odd or eccentric. Then there is Impulsive Personality Index, which is cluster B, which is antisocial, borderline, histrionic, and narcissistic personality disorders that characterize people who have often appear dramatic, emotional, or erratic and have a hard time picking up on social cues. And then there's the Worrying or Personality Index, or cluster C, which would include avoidant, dependent, or obsessive compulsive personality disorders that characterize people who often appear anxious or fearful. So the next part of the GAIN that it entails, and I will go over this all after and bring it all in together so you can actually get a nice picture of what it does. So the psychopathology case mix. So the GAIN is comprised of 4 main scales, which are called psychopathology case mixes. So this includes substance problem scale, the internal mental distress scale, the behavior complexity scale, and the crime and violence scale. So these are the 4 main groups that the GAIN really kind of ties in and what you get your diagnosis out of. So it is not just based solely on a mental health scale or a substance use scale. It takes in all these factors, because out of the GAIN you really want to get a full picture of who the person is and what kind of treatment they actually need. So this is actually a picture of what I went over. So there we have the substance problem scale, the internal mental distress scale, the behavior complexity scale, and the crime and violence scale. So I thought this was just a nice little image that kind of shows you what the GAIN-I entails and how they all kind of fit together in that puzzle that makes up what a person is actually going through and who they are. So next, we're going to talk about some variables in the reports, because we are dealing with people, and obviously people make mistakes, people sometimes don't tell the truth. So these are all variables that we can go over. So it's important to note that the diagnoses are not decided by the criteria. Diagnoses are decided by clinicians who use criteria as guidelines. This needs to be followed, as although it is a very comprehensive assessment, there are variables such as over-reporting, which could be use, symptoms of mental health issues and so on, under-reporting are the same, or symptom suppression. So that could be, if somebody is taking medication and therefore not showing symptoms of a certain mental disorder or what have you. So these need to be taken into account as well. Okay, and then speaking of those variables, so there are reports needed. So there are 2 clinical reports to help address these variables. The first is a validity report, which summarizes possible and definite validity errors found in the assessment. Issues in the validity report should be acknowledged and addressed if flagged items cannot be answered and corrected by the client before the reports are printed. And the second is personal feedback report, which is a full summary of the client's endorsed reasons for quitting and abbreviated summary of the client's endorsed problems and patterns of use. It can be used as part of a motivational interviewing or treatment. So basically it's just a report saying how valid you think the answers are that the client was given. And then the personal feedback is just your own personal feelings on that. So next, still in the GAIN I, which is a very, like we said, a very intense assessment. So these are considerations in diagnosis and treatment planning. So the key is to prioritize these issues by these problems or factors. So the recency, has the problem ever occurred? And if so, when did it last occur? The breadth, how widespread, diverse is the presentation of clinical symptoms or pattern of service utilization, and prevalence, how often has this happened in the past 90 days. So these are big things to keep in mind. Also, considerations of diagnosis, some other factors that need to be included in the decisions. Age of onset, so how long has the person been using or suffering, persistence, how often, functional impairment and role failure, multimorbidity, and history of unsuccessful treatment. So next is just a nice little slide. So the benefits using the GAIN system. So the main, like we said earlier, it's to provide a report that is shareable and usable by professionals in multiple service sectors. It covers a broad range of life areas. Early identification and response to co-occurring disorders and environmental or situational risk factors. It identifies strengths, supports personal resources and interpersonal resources. It identifies and addresses possible barriers to treatment, provides a baseline for monitoring change in problems, support evidence-based practice, and maintains validity and reliability. So diagnosis and treatment. So that was basically the GAIN I, and unfortunately one of our members was sick, so I'm just going to kind of continue on into this part. So as far as diagnosis and treatment for concurrent disorders, oftentimes the tools include motivational interviewing, cognitive behavioral therapy, emotional regulation, skill building, and medication management. So concurrent disorders, as was talked about earlier in our presentation, are very complex disorders with several domains that need attention at the same time. So the treatment requires comprehensive assessments and diagnosis, specialized professionals, and a great deal of time. Clients have the best success when all issues, problems are addressed within the same care plan. And then the last slide that I have for you, I believe, second last, is the diagnosis and treatment continued. So integrated treatment is recommended. Clients have the best success when both problems are addressed in the same way. So integrated treatment is a way of making sure that treatment is smooth, coordinated, and comprehensive for the client. It ensures that the client receives help not only with concurrent disorders, but also with other life areas such as housing and employment. So the treatment usually depends on the type and severity of the person's problems, and they may receive psychosocial treatments for individual or group therapy, or biological treatments, which is medications, or oftentimes both. Yeah, and so the big thing with integrated treatment is both are treated at the same time. Oftentimes, however, it is better to say if somebody's suffering from alcoholism and anxiety, for example, to treat, they need to be sober first, because sometimes, like we said earlier, those symptoms can kind of mimic each other. All right, so the last page is just our resources page. And there are obviously many more: the Royal Ottawa, the Canadian Mental Health Association, Rita Wood Addiction and Family Services, and one that actually we didn't include there, but a great one is the Detox, the Ottawa Withdrawal Management Center, where they do the Q3 and get you set up into treatments, which actually do the Gain I after. So thanks very much for your time, guys. Appreciate it, and good luck on the exams.